Hi class, in this lecture we will review the antibacterial agents. The objectives are listed on the slide and they are also listed in the Blackboard lesson. There is no new vocabulary for this lesson. So let's get started by reviewing the pharmacology of these drugs. So the antibacterial agents work at a variety of sites in the bacteria. And basically they target processes that are unique to the bacterial cell. Some of these drugs inhibit cell wall synthesis, or they can impact the composition of the cell membrane. Some affect folate acid metabolism. Some inhibit the DNA replication process, and others will inhibit protein syntheses. Now, we won't discuss every drug class listed on this slide, but we will talk about drugs that impact the cell in a variety of ways. So there are a lot of drugs in this lecture, as you can see from all of the drugs that you see listed on the slide. These drugs are very important. Not only will these be a big part of exam 3, but these drugs are pretty commonly prescribed. And so if you work, regardless of the setting you work in, you're going to see these. But especially if you end up working in the hospital setting, antibiotics are some of the most commonly prescribed drugs in the hospital setting. There are several additional antibacterial drug classes that are not listed on the slide and that we're not going to ask you to be familiar with. The ones we are going to review are those that are most common, those that you are most likely to see both in clinical practice as well as those we would expect to be covered by the NCLEX. So we're going to start by discussing the beta-lactams. These are the antibiotics that have been around the longest. This group of drugs are called beta-lactams because they all have a beta-lactam ring in their chemical structure. But what's important about these drugs is that they all work in the same manner. Basically, they all disrupt cell wall synthesis. So we're going to start off by talking about those drugs. All right, so the first group of beta-lactams we'll talk about are the penicillins. These are pretty much the ideal antibiotics, and they're also the original antibiotics. They have, for the most part, penicillins as a drug class have a pretty broad spectrum of coverage, and they are considered the safest antibiotics on the market. The oldest drug in this class is penicillin G. In most scenarios, you will hear people just refer to this drug as penicillin. Most people don't actually call it penicillin G. It works because it destroys the cell wall. This causes the cell wall to swell with water and explode. And these drugs are great because they don't cause serious toxicities in humans because the mammalian cells lack a cell wall. Furthermore, we also don't have penicillin binding proteins, which is how these drugs bind. And so because of that, for the most part, they're pretty safe. They don't activate receptors in humans and so forth. Therapeutic uses, these are mostly for the treatment of gram-positive organisms, but they are capable of treating certain gram-negative anaerobes. Now, on the slide, I have therapeutic use narrow spectrum agent. And what I mean is that penicillin G is narrow spectrum, and that means in comparison to other penicillins. Broadly speaking, when we think of penicillins, like I already mentioned, we think they treat mostly gram-positive organisms. But the penicillin G itself is relatively narrow spectrum. Penicillin G, however, is considered the drug of choice for treating syphilis, which is caused by T. pallidum bacteria. It can also be used for prophylaxis of a number of conditions. It can be used for prophylaxis of syphilis. So for a patient with a known syphilis exposure, that patient should receive prophylaxis. It can also be used for prophylaxis for endocarditis patients. So endocarditis patients, sometimes for certain medical or dental procedures, they may receive prophylactic antibiotics, and penicillin G is the drug of choice for that. And also for prophylaxis of rheumatic fever. Dosage forms. This is an important part of the discussion of penicillins. There are 3 different dosage forms. The oral form of penicillin, it's not actually penicillin G, it's called penicillin VK. So chemically, it's just slightly different from penicillin G, But for all intents and purposes, it's considered the oral form of penicillin G. So there is an oral form. And then penicillin G is available in an IV aqueous form. It's either as a sodium salt or a potassium salt. And it's also available in an intramuscular form. The intramuscular form comes in two salts as well, either penicillin G procaine or penicillin G benzathine. This is a very important part of the lecture. You have to know that the intramuscular form of penicillin should never be given by the intravenous route. And that is because of the formulation for the IM form, because it's a long-acting form, it's a lipid formulation, and it's not water soluble. It's not highly water soluble. So it should not be injected intravenously. There's actually a well-known case of an error that occurred back in the 90s where a medication was prescribed, penicillin G benzathine by the intramuscular route was prescribed for a baby as prophylaxis for syphilis. The baby's mother had syphilis. And the pharmacy dispensed a much larger dose than what they were supposed to dispense. And when the nurse received the medication, she recognized that it would take several injections in order to give that amount of penicillin G. And she didn't want to subject the baby to multiple injections. And I'm talking like it would have taken like maybe 7 or 8 injections to give the entire dose because of the volume. And so the nurse asked the nurse practitioner on the unit if the order could be changed to IV to spare the baby all those different IM injections. They did a little research and they ultimately thought it was an acceptable thing to change the route to intravenous. Unfortunately, it was not because, like I said, that drug is not water soluble, and the medication was given to the patient. The penicillin G benzathine was given intravenously to this baby, and ultimately that baby died. And so I'll post that case for you guys just so you can take a look at it. It is, it's worst case scenario. It's what can happen when you don't have all of the information or all of the right information. In this case, it was the result of another error that had occurred upstream, and it's unfortunate. So I want you guys to know IM penicillin, procaine, or benzathine can never be given intravenously. Anytime you have a medication that's formulated for the intramuscular route, you should be asking the question, if it's ordered for the IV route, you should be asking the question, is this appropriate? Because it might not be. All right, so here's your name recognition slide. So the good thing about the penicillins is that they all end in -cillin. So when you're in practice, even though today I'm telling you the only one you need to know is penicillin G, because that's our prototype, I'm telling you that it's going to be easy for you to recognize these because they all end in -cillin, as you can see on the slide. And so there are several categories of penicillins. What you need to know for the test is highlighted, so it's highlighted in red. You need to know that -cillin is your name recognition for penicillins, and you also need to know penicillin G and all the properties of penicillin G, since that's our prototype. Now, the good thing is, if you know penicillin G, you're really going to know the penicillins kind of at large because for the most part, these drugs are all very similar. Where they differ is really just around their coverage. So you can see in the chart on the left-hand side, your penicillin G is a very narrow spectrum drug. But as you go down the chart, you can see that the spectrum increases. As you go down successively down the chart, the spectrum of coverage definitely increases. The other thing that's different is whether the drugs are available orally or IV. So I did include that information on your slide. Again, I'm not asking you to memorize that for this exam, but I do think it would be smart for you guys to be familiar with these drugs because you are going to see them in clinical practice. At least be familiar with the different names. Some of you, or actually all of you, are already doing your clinical work. You've already started to do your clinical work. I'm sure you've recognized some of these names. You might recognize amoxicillin, for example. At the bottom of the chart, piperacillin tazobactam, or Zosyn. That's a very commonly used antibiotic in the inpatient setting. So I'm sure you have seen these before, you've heard these names before. One last thing before I move on from the slide that I want to point out. Again, this is not because I'm going to test you on it. But this is really because I think for clinical purposes, even right now as you guys are on your clinicals, I think it's a good thing for you to know. the very last section, the last row, the penicillins that are combined with a beta-lactamase inhibitor. So beta-lactamase is an enzyme that destroys penicillins. And essentially, one of the mechanisms of resistance for penicillin is that the bacteria can produce this beta-lactamase, which destroys the antibiotic. So the drugs in this last column are unique in that they are penicillin drugs, but they're combined with a beta-lactamase inhibitor. And what that component of this drug does is prevent the breakdown or the destruction of the penicillin. So the beta-lactamase inhibitor itself has no antibacterial activity. All it does is just prevent that penicillin from being broken down by the bacteria. So that's why all of these drugs have two names. So amoxicillin is the penicillin component, clavulanic is the beta-lactamase inhibitor, and so forth. All right, so let's talk about adverse effects. As I said, these adverse effects are going to be similar across all of the different penicillins. Penicillins are considered the least toxic of all antibiotics. They're considered to be the safest drugs, the safest antibiotics on the market. The biggest concern, however, with these drugs is allergy. And we'll talk more about allergy in a couple minutes. I'm going to talk about the rest of the AEs before I talk a little more in depth about allergy. So these drugs can also cause nausea and vomiting in as much as 10% of patients. That is something that patients typically do complain about. They can cause renal impairment when the drugs are used at very high doses. And so this is kind of a twofold issue. If the patient has underlying renal impairment, the renal impairment can be worsened. And the drugs themselves, if they are prescribed in very high doses, can actually cause some degree of renal impairment. Hyperkalemia can also occur, but that's with a specific form. That's with the Penji potassium salt. Because of the high load of potassium in that formulation, that can result in hyperkalemia if the patient's getting a very high dose. Seizures, again, this tends to not be something we worry about for most patients, but if you've got a patient who's got pre-existing renal failure, if their drug dose is not appropriately adjusted, then a concern would be seizures at high doses. And then the last adverse effect I want to mention is adverse effects that are specific to penicillin G procaine. So that is one of the IM forms of penicillin G. Because of the procaine component, some patients experience anxiety, hallucinations, confusion, palpitations, and that's not related to the penicillin, that's related to the procaine component. All right, so let's talk about allergy, because this is the main concern that we have with penicillins. So first and foremost, anytime you're caring for a patient who is prescribed penicillins, first thing you're finding out is whether they've ever had whether they have a penicillin allergy. So you're always asking them, do you have a penicillin allergy? Before every single time you administer the med, you're asking, do you have a penicillin allergy? These allergies can be just a simple rash, all the way up to life-threatening anaphylaxis. So they can manifest in a variety of ways. Generally, drug allergy is not related to the size of the dose. So the allergy itself is not necessarily more likely. It's not more likely if the person's getting high dose penicillin versus low dose. Really, all that's needed to have a penicillin allergy is some prior exposure. That prior exposure can be an actual course of antibiotics, or it can be exposure through the dietary sources, because a lot of livestock are routinely given antibiotics, and even an exposure of that nature could potentially elicit an allergic response in a patient. It's very important to appreciate the issue of cross-sensitivity. So first of all penicillins, so I showed you that chart of all those different penicillins. Patients who are allergic to one penicillin should be considered allergic to all penicillins. Furthermore, cephalosporins, which is the next drug class we'll talk about, if someone's allergic to penicillin, then they should be considered allergic to cephalosporins as well. Now, the issue about cephalosporins, whether or not you'll actually still use the cephalosporin in someone who reports a penicillin allergy really depends on what they report. So if the patient says that In the past, I had, some kind of mild reaction to penicillin, and now they've got some kind of very serious infection, and the drug that should be used is the cephalosporin. Most likely, we would go ahead and proceed with therapy. However, if the patient said to you, "Yeah, I was on penicillin and I developed Stevens-Johnson syndrome and all of my skin sloughed off," well, you can pretty much bet that there's no prescriber that's going to prescribe a cephalosporin after hearing that. So it does depend on the type of reaction, because there is about a 1% risk of cross-sensitivity. Now, in terms of the types of reactions that you expect to see with penicillin, so penicillin reactions can be classified as immediate, accelerated, or delayed. Immediate reactions occur 2 to 30 minutes after the drug is given. Accelerated reactions occur within the first 72 hours, and then delayed reactions occur within days to weeks. The type of reactions that we're most concerned with are the immediate reactions. And the accelerated and the delayed can also be of concern, but our heightened concern is around the immediate reactions, and these are IgE mediated. So they can cause anaphylaxis, which would manifest as laryngeal edema, bronchoconstriction, severe hypotension, basically a life-threatening situation. And so the good thing is that the incidence of anaphylaxis is pretty low. So it's estimated that the incidence is between 0.004% and 0.04%. But the problem with this is that even though that's a low percentage of patients that will develop anaphylaxis, of those patients that do develop anaphylaxis, mortality is about 10%, which is high. So this is a medical emergency. The primary treatment is epinephrine plus respiratory support. And, again, it's a medical emergency, so you have to kind of intervene as quickly as possible. So just because a patient is allergic, say you have a patient that said, "Oh, I had an anaphylactic reaction when I was a child to a penicillin," it doesn't mean that 30 or 40 years later, they're still allergic. I mean, there's probably a high likelihood they are, but it doesn't necessarily mean definitively that they are still allergic. So because this allergy to penicillin can decrease over time, in some cases, patients will have skin testing done to see whether or not they're still allergic. And the skin test basically is observing for a local response. And so, a positive test will indicate that the patient has IgE antibodies. And so this means that they could still have that they still have a severe allergy. So skin testing is not something that we're going to do kind of in an urgent situation. Skin testing is something that you do, if you've got this allergy and you want to have it tested, that's kind of a preemptive thing that you would do. But if you've got a patient that's in anaphylaxis, you're going to treat them with epinephrine and respiratory support. You're not going to call for a skin allergy test. So alternatives. So if you have a patient that reports this allergy, some alternatives. Vancomycin, which we'll talk about in a few moments, could be used. Clindamycin, erythromycin, these are other antibiotics that have similar spectrums of coverage that do not cross-react with penicillin in terms of the potential to cause allergy. One last thing I want to mention, it is possible to do what's known as a desensitization. So for a patient who does still have IgE antibodies, these patients can be desensitized, but this can be risky. It's very complex, and it certainly can be risky. It would really only be done if you've got a patient that's got a life-threatening infection where penicillin or some form of penicillin is really the only appropriate therapeutic choice. And if that's the case, there are going to be all kinds of people involved in that decision. That's not a decision that's made by a general care practitioner. You're going to have infectious disease people involved. You'll have allergy and immunology involved. Pharmacy is going to get involved. This is really a big kind of coordinated effort because it is so risky to undertake one of these protocols. All right, individual variation. So if again, very important to ask, are you allergic to penicillin or other beta-lactams? upfront, making sure that you're always assessing that before you administer penicillins. Secondly, assessing renal function, because renal dysfunction means that the dose for these drugs and possibly the frequency may need to be adjusted. And if they're not, then drug accumulation can occur, and that can lead to problems such as seizures, which I already mentioned. So individual variation, assessing renal function would be very important. Nursing implications. So in reference to allergies, number one, always asking about allergies. I think I've said that 5 or 6 times at this point. Monitoring for allergic reactions for 30 minutes after drug administration. Some other issues, these drugs are not compatible with aminoglycosides. And so for some infections, penicillins are used in combination with another drug class called aminoglycosides, which we'll talk about. And so these drugs should never be mixed together in the same IV line. And that's because the penicillin has the potential for inactivating the aminoglycoside. And so you don't want that to happen. So they shouldn't be mixed together. In terms of patient education, for all antibiotics, we're going to say the same thing. Educating patients to take the entire prescribed course of therapy, even when they're feeling better. Specifically for penicillins, making sure you are educating patients to observe for signs and symptoms of allergy, such as skin rash or hives or itching, and making sure that they report that immediately if they experience any of those symptoms. And then, of course, if they are penicillin allergic, making sure they know they should be wearing an ID bracelet for that. That is a very serious allergy to have, and they should be letting people know about it. So some safety concerns with penicillin. First of all, the biggest concern, I cannot stress this one enough, you've got to be familiar with the mix-ups with the IM and the IV dosage forms. So remember, certain formulations can only be administered via the IM route. So penicillin G benzathine, penicillin G procaine, these are both formulated for the the IM, the intramuscular route only. They should never be given via the IV route. Other potential safety concerns, CNS toxicity in an overdose scenario. So if the patient receives a massive overdose, they are at risk for seizures and other types of CNS issues. Or if you've got a patient with severe renal dysfunction and their dose is not adjusted, or their interval is not adjusted, they are at risk for CNS toxicity. All right, so let's move on to our next beta-lactam drug class, and those are the cephalosporins. The prototype cephalosporin is cephalexin, brand name is Keflex. These drugs also inhibit the synthesis of the bacterial cell wall, which results in cell lysis. These drugs are generally active against a broad spectrum of drugs, for sure gram-positive organisms, but you'll see I have a chart on the next slide, very similar to the chart I had for penicillin. And you'll see as you go down that chart, your coverage will broaden as you go down the chart. But historically, these drugs are used for gram-positive organisms. There's also pretty low toxicity associated with these drugs. And these are probably, I would say these are actually not probably, certainly the most widely used group of antibiotics on the market. They are grouped into different generations. So they go from first generation all the way through to the 5th generation. Now, for our purposes, you guys need to only know one of the cephalosporins, and that is our prototype, cephalexin or Keflex. So in terms of individual variation, similar to the penicillins, renal dysfunction is an issue with cephalosporins. All of the cephalosporins are eliminated from the body by the kidneys. There is just one exception, and that exception is ceftriaxone. Ceftriaxone is eliminated through hepatic metabolism and excretion. So for our purposes, no renal dysfunction. The main reason that that's an issue is because in cases of severe renal dysfunction, the dose will need to be adjusted. I already mentioned the potential for cross sensitivity between penicillins and cephalosporins. So if you have a penicillin allergic patient, then those patients, you need to dig further and get more information to find out whether that patient should or should not get a cephalosporin. Generally speaking, if you can avoid giving them a cephalosporin, you should, but in some cases that's not an option. All right, so here's your name recognition slide. Obviously, it's got a lot more information on it. What you need to know is highlighted in red. The rest of this is just informational for you guys. I put this together because I think you guys are going to see these drugs in real life. Now, it's the way pharmacology is taught is to just teach the prototype. But because I know you're going to see a lot of these drugs, I thought it was a good idea to put the slide together for you. So definitely know that CEF or CEPH. If the drug starts with that, then that means it's one of the cephalosporins. The one that you need to know, I already mentioned, is cephalexin, or the brand name Keflex. That's our prototype. Now, the good thing about the cephalosporins is they're kind of like the penicillins. If you know the uses and the adverse effects and the safety concerns, those are pretty consistent across this class. The monitoring parameters, the nursing implications, these are going to be pretty similar across the class. Where these drugs differ, again, going back to your first generation drugs, which are at the top of the slide, all the way down to your fifth generation drugs, the difference is really with whether or not there's going to be a gram-negative coverage. And because these drugs cover gram-positive organisms, the question is, do they cover gram-negative organisms? As you go down the slide, from the first generation to the fifth generation, you're going to see an increasing amount of gram-negative coverage. So the drug with the most gram-negative coverage on this slide is the fifth generation cephalosporin, ceftaroline. The other way that these drugs differ is whether or not they're given oral or intravenously, so that information is listed. And then one other factor that does kind of differentiate the cephalosporins from each other is whether or not they can distribute into the cerebrospinal fluid, or put another way, whether or not they cross the blood-brain barrier. So you can see that information. Again, much of what's on this slide is informational for you guys. Like I said, I include it because I think as you are entering your clinical practice and you're comparing these different drugs, for our purposes, you just need to know the prototype. But as you begin to see these drugs in practice on your clinicals and when you become registered nurses, this is just some additional information to help you kind of navigate the use of the cephalosporins. All right, so adverse effects. As I mentioned, these are going to be consistent across this drug class. The biggest issue is hypersensitivity, very similar to penicillins, again. So our major concern is that patients could develop allergy to these medications. As I already mentioned, there is the potential for cross-sensitivity or reactivity for a patient who is penicillin allergic. The risk is estimated to be about 1%. But again, if you have a patient that reports a very serious reaction, such as anaphylaxis or maybe one of those serious skin reactions like Stevens-Johnson syndrome, those are so serious that these just would not be even any entertaining of using a cephalosporin in those patients. Like I said, unless they have a very serious life-threatening disease and or infection, and the only drug that can be used is a cephalosporin. So we generally try to avoid these drugs in patients with penicillin allergies. Very similar to the penicillins, these drugs can cause nausea, vomiting, and diarrhea. And the incidence is pretty high, as many as 10% of the patients who take them. Some other rare issues. C. diff colitis, it is pretty rare, luckily, but that is a possible side effect, especially as the spectrum broadens. So as you go from your first generation down to your fifth generation, C. diff colitis will be more common as you increase the spectrum of coverage. Bleeding is possible with two particular drugs, cefotetan and ceftriaxone. Hemolytic anemia, again, pretty rare, but it is something that it is an adverse effect that could occur with these drugs. And then I already mentioned seizures with penicillins. Same scenario for the cephalosporins. If you've got a patient who has pre-existing renal impairment and your cephalosporin dose is not adjusted appropriately, the drug can accumulate, and at those high doses, which translate into high levels, you could potentially see seizures. Some nursing implications. Ceftriaxone in particular, I know it's not our prototype, but nevertheless, this is an important nursing implication related to cephalosporins. Calcium and ceftriaxone should not be given together in the same IV line. Ceftriaxone is a pretty commonly used drug in the hospital setting. And then, of course, calcium, as is all of your different electrolyte replacements, are pretty common therapies in the inpatient setting. These drugs can cause phlebitis, so you need to monitor the IV site. And then, of course, education. Like I said, for all of the antibiotics, we're going to educate patients to take the entire prescribed course, even once they're feeling better. But specifically to cephalosporins, if they do experience signs and symptoms of allergy, those should be reported to their provider as soon as possible. And if they are known to have a cephalosporin allergy, they should be wearing an allergy bracelet. In addition, patients should be advised to avoid alcohol with cefotetan or cefazolin, which are two specific cephalosporins. Again, they're not our prototype drugs, but for those specific cephalosporins, alcohol should be avoided, and that's because it can these patients can develop a disulfiram-like reaction, which is really uncomfortable for patients. It causes pretty intense flushing and nausea, and other similar symptoms. All right, let's move on to the last beta-lactam that we're going to talk about, and that is the carbapenems. Our prototype carbapenem is imipenem, and the brand name is Premaxin. This drug also binds to the bacterial cell wall and inhibits peptinoglycan synthesis, which really just means that it causes cell wall lysis. Therapeutic uses, these drugs are extremely broad spectrum. That means that these drugs are going to be reserved for patients with highly resistant organisms. Since they cover so much, we want to reserve these drugs for treatment of serious infections. So this is one of those drugs that, remember when I was talking about general principles of antimicrobial therapy, and I talked about the fact that at an organizational level, most institutions will have an antibiotic approval system in place. They'll have an antimicrobial stewardship program. These drugs are definitely going to fall in that group. Because they are so broad spectrum, they can lead to resistance if they are used inappropriately, number one. Number two, we want to reserve the use of these drugs for those highly resistant organisms. And so these are definitely going to fall kind of within that realm. In terms of adverse effects, again, like a lot of other antibiotics, nausea, vomiting, diarrhea, you could potentially be seen. I highlighted seizures, and I think that's a really important one for you guys to know for a couple of reasons. First of all, seizures are the major concern associated with these medications. These medications lower the seizure threshold. And that combined with the fact that for patients who have a seizure disorder, valproic acid is a pretty commonly prescribed anti-seizure medication. And so not only do these drugs lower the seizure threshold, but in addition to that, when the drug is used together for a patient who is also receiving valproic acid, it will reduce the levels of valproic acid, which can lead to therapeutic failure. So for those two reasons combined, I think this is something you guys definitely need to know. When I worked at Hopkins in the Children's Center, I saw this happen probably once every other month. There was a problem with a patient that was admitted to the ICU who was receiving a carbapenem for a serious infection. Maybe they either had an underlying seizure disorder or they had developed issues with seizures, and they were on valproic acid, and their levels dropped and they ended up seizing. So please be familiar with this issue. Additionally, these drugs can cause thrombocytopenia, and just like the cephalosporins, these drugs can be cross-sensitive, meaning, so 1% of patients who are allergic to penicillin or a cephalosporin, the carbapenems, they could potentially be allergic to carbapenems as well. So again, just like that evaluation process exists for a patient who you might want to give a cephalosporin to, if they're already allergic to penicillin, you've got that same kind of discussion around a carbapenem. And then these drugs can cause hypersensitivity reactions as well. Again, just like the penicillins, the dose is adjusted in renal dysfunction. All right, so let's move on to vancomycin. Vancomycin also inhibits cell wall synthesis. And so it does it a little differently from the beta-lactams that we already talked about, but essentially, for all intents and purposes, its activity, kind of what it does to the cell, is very similar. Therapeutic use, gram-positive only. This absolutely does not cover gram-negative organisms, so only your gram-positive organisms or infections caused by gram-positive organisms will be susceptible to vancomycin. Please know that this is the drug of choice for treating MRSA, which is methicillin-resistant Staph aureus. So serious staphylococcal infections, for patients who are allergic to penicillins, that is another use for this medication, or cephalosporins or carbapenems. Again, because vancomycin is the drug of choice for MRSA, this is a drug that we do our best to reserve its use for appropriate scenarios. So if you've got a staphylococcal infection that's susceptible to a penicillin or a cephalosporin, it would be preferable to use one of those drugs. But if the patient has a serious allergy and they're unable to get those drugs, that's when vancomycin would be considered. Additionally, this drug is also used to treat C. difficile, which is a GI infection. The oral dosage form is used to treat the C. difficile, and that's because this drug is not absorbed orally. So it is a localized effect in the GI tract, and actually that kind of brings me to a second point that's associated with the fact that the drug's not absorbed orally. I can't tell you how many times when I worked as a pharmacist, I would receive a call from either a nurse or a prescriber asking, is there an oral dosage form of vancomycin? I could have very simply answered that question, yes, there is an oral dosage form of vancomycin. Thank you very much, have a good day, and hung up the phone. But I never did that. I always said, well, why are you asking? Because my fear was that somebody would not, on the other end of the line, would not know that even though there's an oral dosage form, that oral dosage form is only for treating C. diff because it's localized in the intestines. It's not absorbed orally. So if the person on the other line was calling me to ask whether or not their patient who had a systemic infection, let's say MRSA infection, they wanted to discharge that patient because they were starting to do better and they were appropriate for discharge, and they were asking me could they continue or complete the course with oral therapy, my answer would be no, because this drug's not absorbed orally. And so if you give the oral dosage form, it will not have any systemic actions. So keep that in mind. That's a really important, very, very, very important thing to know about vancomycin. Obviously, it's available in the intravenous form and the IV form. Individual variation, this drug can lead to renal dysfunction, and this drug also needs to be dose reduced in renal dysfunction. Adverse effects, I already mentioned it can cause nephrotoxicity. Generally, this is more common when your levels are higher than 20 milligrams per deciliter. So this is one of those drugs where we empirically start our patients on a dose. Usually it's 15 milligrams per kilo per dose. And then we get levels to monitor therapy. And I'll talk about that in a moment. Let me talk about the rest of the adverse effects before I talk about how the drug is monitored. Ototoxicity can also potentially occur. It's unclear whether or not this drug really causes ototoxicity. In many cases, this drug is combined with other drugs that are ototoxic, or it could be a formulation issue. Back in the 60s and 70s, the formulation was not as pure as it is today for this medication. So there's some thought that some of that ototoxicity was from an impure formulation. But it is something that we still assess. Phlebitis, this drug does have the potential to cause phlebitis, so the IV site is monitored. And the main, aside from nephrotoxicity, the main adverse effect I want you guys to be familiar with is red man syndrome. Red man syndrome is characterized by flushing, rash, pruritus, urticaria, tachycardia, hypotension. These are all infusion-related reactions that occur when the drug is infused too quickly. So because of that, we extend this infusion over at least 60 minutes. So some nursing implications. First of all, the drug should not be given via the IM route because it can cause pain and tissue necrosis. It should be administered over at least 60 minutes. I can tell you that in some patients, they require an even longer administration time. If the patient has a bad reaction, a red man's type reaction, in some cases, it'll be given even over 2 hours, or even sometimes, I guess, even longer. Hopefully not, but uh, that can be done to minimize that infusion-related reaction, which, by the way, is related to a release of histamine. So sometimes, even for patients who you extend the infusion time, they may also be pre-medicated with Benadryl because it is related to a release of histamine that causes that reaction. I already mentioned that levels are used to monitor therapy. So like I said, generally there's an initial dose that's given and then levels are drawn. For vancomycin, I would say probably 95% of the time we're just drawing a trough level to monitor therapy and to adjust the dose. Uh, there could be some scenarios where you also get a peak, but usually it's just a trough. Finally, if the patient is on oral therapy, they should be instructed to complete the entire course. Okay, let's talk about the next drug class, and that is the tetracyclines. Now, our prototype is just simply called tetracycline, but there are several other drugs in this class. For example, minocycline, doxycycline. These are other drugs in this class you may have heard of, but our prototype will be tetracycline. It works by inhibiting protein synthesis. Specifically, it binds to the 30S ribosomal subunit, and that has impact on RNA transcription and so forth. Bottom line, it's a protein synthesis inhibitor. This drug actually used to have a pretty broad usage. However, its use really has declined in recent years because of resistance. But it is still pretty good for a few things, such as atypical organisms like rickettsia or spirochetes. It also can be used for the treatment of acne. A bacteria that causes acne, it's called Propionibacterium species that causes acne, and the tetracyclines are active against that particular bacteria. It's also used in conjunction with several other medications to treat peptic ulcer disease, and that's because one of the causative agents of peptic ulcer disease is Helicobacter pylori. So this drug is used in conjunction with a couple other drugs to treat peptic ulcer disease. And then it can also be used for periodontal disease. Some of the adverse effects, so GI irritation, such as nausea, vomiting, diarrhea. But the one I really want you guys to know, there are a couple that you really need to know. Number one, dental effects in children. This drug should never be used in children under 8 years old. And that's because it causes discoloration of the deciduous teeth. These are developing teeth, and so this drug can cause the patient's teeth to be permanently discolored. And it's kind of like a brownish orange discoloration. It's very noticeable, and it's not very appealing. So for children that are exposed to these drugs, it's a bad side effect. And it's not just limited to children under 8, actually pregnant patients. So pregnant patients, because the drug does cross the placenta, the drug can actually cause this problem even in utero. So should not be given to pregnant patients, should not be given to children under 8. The other big adverse effect of concern is photosensitivity. Photosensitivity with tetracyclines can be profound. So patients who are on these medications must be instructed to use sunblock and to stay out of the sun because they can get very serious burns as a result of this drug and its photosensitive properties. Some others, vestibular symptoms like dizziness, headache, vertigo. This is especially likely with minocycline. This drug can also cause superinfection. So individual variation. So patients with kidney dysfunction, the drug dosage needs to be adjusted. Pregnant or lactating patients, as I already mentioned, they should not receive this medication. And then, of course, children under 8. Drug-drug interactions. The tetracyclines can form a non-absorbable chelate with certain metal ions, such as calcium And so think of dietary sources of metal ions. Milk is one of the biggest dietary sources, so these medications should not be taken with milk. Calcium supplements, even calcium supplements that are used for heartburn, antacids. So these medications need to be separated from the tetracyclines. So nursing implications, you can instruct patients to to take this medication with a full glass of water, and that can help minimize some of the GI upset. And then, of course, you have to instruct them not to take these medications with milk or other dairy products, or even iron or antacids or even calcium supplements. So the tetracycline should be given 1 hour before or 2 hours after these different products.